Permission to share screen?
Yes, I have.
Beautiful. Right, AJ, as the maitre d', can you see only my presentation now?
Yes, I can see only your presentation. You're good.
Outstanding. Hopefully this works then. Right, so I will introduce myself. My name is Jonathan Dennis. I'm one of the CT2s in ENT currently, well, the only CT2 in ENT working at List Hospital in Stevenage. AJ asked me to do this a couple of months ago and I've not found a good way to get out of it. So my background is I'm a Max Fax training by background. I did dentistry first. Then I did a couple of years of working. Then I did medicine. While I was there, I was working at Nottingham. I did 4 years at QMC while I was doing nights while I was at uni. Then I did my foundation training. Then I'm doing this. So this is a basic overview of pediatric ENT emergencies. The purpose of this is for exposure rather than competence. Ideally, everyone is super competent. But a lot of the time, if you're thinking about these things or you know who to call or you know who to ask for help, these days that is good enough. Ideally, everyone manages everything and I get to find a nice bed at night, but the world unfortunately doesn't work like that. So we have the first thing on the right there, and the way I'll be going through this presentation is I will be asking some questions, mainly to make it slightly more interactive and to give me a subtle time to drink my coffee. There will be feedback at the very end, especially on my terrible presentation technique. Can I ask anybody, perhaps those that are definitely much more pediatric background, what lovely character they think is currently lodged slightly high up in the little one's throat?
SpongeBob SquarePants.
It is indeed SpongeBob SquarePants. It is amazing what you can find on Google. And part of this is essentially, we know what SpongeBob looks like, it's pattern recognition. And ignoring all the posh Gucci management, everything else you can do, a lot of this is pattern recognition. And when you hear the story, you know what's going on here. So this is the thanks to all the people I've shown this presentation to. And I said, what else would you want to do? The only one to tell me that they wanted to add on something else more was Miss Stevens, who is one of my consultants. So I have something to add on at the very end, thanks to her. So thank you to all these individuals there. So we should have a relatively agreed presentation from the ENT department at Lister, which also covers Watford out of hours in terms of pediatric ENT emergencies. So in terms of the presentation delivery, it's jumping slides already, excellent. So normally I teach on teams. My background is I'm also an Army reservist and we do a lot of our training on teams because of the whole COVID issue. So I've stolen a slide from that. Video off, please. Microphones, you can mute unless speaking, especially if you're eating crisps. Unfortunately, I can't mute. There'll be opportunities during the presentation, after the presentation, to ask questions. If I do not know the answer, I will find someone that does and I will get back to you. And clearly virtual hands up. I can't see the chat very well because otherwise it will ping up, but I trust AJ to spam me if there's any dire emergencies. And if at any point you stop hearing my voice and I'm talking, probably it's because I probably managed to mute myself. So someone please let me know. The learning objectives, this is what I'll be covering today. So I will be looking at foreign bodies, epistaxis, trauma. Won't be looking at safeguarding from that aspect because I expect that everyone else here on the call is far more of an expert in safeguarding than I am. Peritonsal abscesses, the dreaded quinsy. It's never a quinsy until it is. Retropharyngeal abscesses, not that common, slightly more common during COVID due to various issues. There's something to be aware of in your differentials. Adenotonsillectomy bleeds, especially for the little ones that present, they're more likely to get an adenotonsillectomy. So we take the adenoids, we take the tonsils. When the adenoids bleed, they bleed like stink. And it can be a bit confusing to work out where they're bleeding from. Epiglottitis, Mastoditis, and orbital cellulitis. And the way I've divided this up is into ear, nose, and throat. So, does anyone know who this lovely character is?
Dumbo.
Exactly, thank you. Just the thing there. I wanted to put lots of GIFs in because I'm trying to improve my presentation skills and watching far too many TED Talks. So starting with the basic anatomy, what do we have? We have the external ear, the middle ear, and the inner ear, or as Teach Me Anatomy put, the internal ear, a wonderful website. A lot of what ENT get called down to see is normally an issue with the external ear, but occasionally people think it's an issue with the middle ear. Normally there's no communication between the external ear and the middle ear, and very rarely in my job at a minion level do I ever really deal with the inner ear. All the weird balance disorders, everything else, very rarely affect children. Vertigo, very, very uncommon in children. Very, very uncommon. And almost always we worry more about a central cause then. And dizzy patients from an ENT perspective very rarely present with a true presentation to the emergency department, even the mid-years patients. They tend to come more back to clinic. What we'd always get worried about is a pox. Pox is being very, very uncommon in children, thankfully. You occasionally get communications from the middle ear to the external ear. Normally when someone like myself puts a sharp pointy instrument through and tries to do a grommet and then has to ask for help. So it's the basic anatomy from there. What we do get is we get this lovely communication, and hopefully if I'll be able to annotate there. Can we see my mouse on the screen?
Yes.
Excellent. Hopefully this continues working. What we tend to see then is this communication from the middle ear down the eustachian tube, which is shorter and straighter in children and goes right to the back there of the nasopharynx, around the areas where if you get particular adenoids, they can obstruct the area. So that's one of the reasons that if we get a child that has a glue ear or mucus in this area here, we will take the adenoids out sometimes and increase their risk of an adenoid bleed because they weren't bleeding before we started surgically attacking them from there. Apart from the other basic ear, just because I said I'd go through it. This area, the lobule, has no cartilage. Children occasionally get lovely piercings put through that get infected. All the cartilage exists along this area here. If we're thinking of people that come in with trauma and they have a perichondral hematoma or the lovely then cauliflower ear that develops from there, it's almost always in this area here that it develops because that's where the trauma is. Again, very, very uncommon in children, but if you're worried about it, we're always happy to have a look at the little ones because it's a right bugger to reconstruct if you have to. So again, basic ear anatomy. Even now, when I'm doing certain documentation, when I'm worried about this potentially then going to police reports, I will get up an image to make sure I've labeled everything exactly perfectly. If we know roughly where the anatomy is, then it's a lot easier when we're discussing things over the phone, especially from referral centers. Next thing is the absolutely delightful tympanic membrane, which is super fun to look at. If it looks roughly okay, it's probably okay. Once you've seen a couple of normal ones, then you'll know what the abnormal will look like. It's always really fun to examine a child who's screaming and trying to hold them still to actually have a good look at the eardrum to see what's going on. If you can see the cone of light, so you can see the light reflex, then you know one, which way the eardrum is pointing, and two, things are probably okay. Because the cone of light is normally where you're going to get the most dependent area of mucus flowing down there. So if there's an infection and you can see the cone of light, then we're normally pretty happy. The rest of that stuff is mainly just for interest. But now we'll start going on to what is abnormal. Can anyone tell me what they think is going on here?
Looks like it could be a otitis externa infection.
Yep, I would thoroughly agree. And so we typically quite commonly get referrals for Mastoditis, not from the emergency department on this, because I expect you seem far more acute there, but typically more from general medical practice then. And so what we see is that we've got someone with a discharging ear, and the concern that they have is this Mastoditis because the ear is red. And the ear will be red because what can happen is it is an infection of the skin of the external ear. This is completely separate normally to the internal ear. Even if someone has a grommet, they can still get otitis externa. And so they complain of discharge because it's producing loads of gubbins, pain because it hurts like hell, itching being one of the signs, kind of infection, inflammation of the ear. Itching is what we always ask for, and the hearing loss. The hearing loss can happen because the tympanic membrane, the eardrum, has got 3 layers to it, one of which is joined to the skin of the outer ear, and that will be inflamed. If it's inflamed, it doesn't move as well. They get hearing issues. Tends to be caused by Pseudomonas, Proteus, or Staph aureus. So we're talking Staphylococcus aureus. In terms of it, though, most of the time it's a Pseudomonas infection. And this is when we ask about the history. Have they been swimming? Are they a child that likes to put their head under the bath? Do they get pain after? If someone's got a load of earwax and the water's getting trapped behind there and can't drain out, they have the increased risk. And this can happen from trauma as well. So people getting lots of cotton wool, buying things off Etsy to self-clean their ears, can do all these type of things. If someone starts with an infection on the outside, on the lobule, because they've had a piercing, it's technically not an otitis externa. Our treatment is almost very similar, but a lot of the time, the way we treat these patients, strict water precautions. We tell them not to put their head underwater, which they never listen to us on. Topical antibiotics, we tend to give ciprofloxacin. Even if there's a tympanic perforation, ciprofloxacin is safe. And the way that we treat otitis media with someone who's got a grometin is that we'll give them topical ciprofloxacin drops. Even if the swabs say it's intermediate or potentially resistant to ciprofloxacin, the concentration that we give in the drops is far higher than the oral concentration dose. So you can normally just increase the dosing regime to beat that out. But we tend to speak to micro if we're struggling with these patients. When there's this much discharge, we will try to get these children to clinic during the day, normally first thing in the morning, because it can be a little bit of a battle, to try to clean out the ear, clean out all that debris. Very rarely, but it does happen, is the ear canal starts to narrow down a bit. And so this is when you'll hear about the lovely Pope wick, which is essentially a tampon for the ear. And people really enjoy having it in because it's very, very scratchy. What we do in clinic is, having cleaned it out, we will pop it in and put some drops on with some steroids. Sometimes if compliance is poor, we'll fill the ear up with an ointment as well. Children don't particularly like it because it makes them completely deaf on one side, because we essentially give them a conductive hearing loss by filling up their entire ear canal. If you're looking at a child and they've just got a discharging ear, there's not too much, and the tympanic membrane looks intact, they can have some ciprofloxacin drops, water precautions. If it's spread to the external ear and they're well, then they can most likely go home with some Comoxiclav and some topical drops. But these are the children we'd want to see and follow up, because the risk is if the infection gets really bad, they lose the shape of their ear, and then nobody's happy. Are there any questions about otitis externa?
No, I think we're fine.
Beautiful. I do very much appreciate that this may come across as trying to teach people to suck eggs. So if I am, just tell me off. What's going on here?
Tympanic membrane bulge.
It is indeed. So what we see is bulging of the tympanic membrane. And the beauty is that a lot of the stuff we teach in ENT these days, we don't really see anymore. We don't see it that commonly because we have antibiotics and we have really good primary healthcare physicians. And we, regardless of what's been written, we still have people working very hard in the healthcare network. So a lot of these conditions in the part are almost historical that we don't see. What we see here, bulging tympanic membrane, what happens? Well, either it will continue bulging and at some point it will pop, in which case the child will get a lovely amount of discharge. They'll start feeling better and things will start improving, or it won't. And it's the won't that's more concerning. So what we see here, we've got a serous otitis media, there's fluid in the middle ear. We think this is probably because the eustachian tube isn't draining properly, or it's got blocked. And we know it's shorter and straighter in children. And so they did try to give decongestants. But what can sometimes happen is this then gets infected. Because much like leaving a hematoma somewhere, it's great. Bugs love it, something to grow in. So otitis media, infection of the middle ear infusion, can be viral, can be bacterial. Most of them self-resolve. The concern is if it doesn't. So for a child like this with a bulging tympanic membrane, I would give some antibiotics. If they're not getting better, we very rarely do acute grommets, which is draining of these in an acute situation, but it has been done. And that's typically when we think they're going towards Mastoditis. Mastoditis is what scares us and what scares everybody. People are very worried about missing one. And if you see a bulging tympanic membrane in a child who's very, very unwell, this is a child I really want to see. And we're looking then about the venous connection to the brain for Mastoditis. And then that goes on to the next one. So we've got the mastoid area, your mastoid hair cells, they get some infection in, it then starts swelling, and then you get an ear bulging forward. This is what a Mastoditis looks like. Because we do not see them very commonly anymore, unfortunately, an adult died a couple of months ago of Mastoditis. It's now in the area that everyone's very concerned about. You need to normally have a history of otitis media. If there's no history of otitis media, and there's no history of any weird ENT intervention or anything else, then actually Mastoditis is very, very unlikely. Common things happen commonly. This is not common, especially with our antibiotic therapy. It does still happen, but it's more of things that someone is concerned about. You're seeing the pinner push down and forward. This is a child who we need to see. When we get really worried is the same things you would be worried about. If the kid's drowsy, if they're super irritable, and that obviously means something different to peds to my level of irritability. If they've got a terrible headache, if they're vomiting, if they're complaining of pain behind the eye, or if they're trying to cover up their eye because they're developing blurred vision or diplopia. And the treatment for this is always a multi-team approach. They end up being stabilized in the emergency department. And then this is when I'll come in, I'll look at them, and then I'll call my boss. And we'll look at going to theatre to essentially drill out this area here, open it up, do a cortical mastoidectomy, take it out, take out all the bone, and try to drain the area. Never let the sun set on pus. And the reason we get very worried is we care more about it's going to spread to. And so what we can see here is we can see a very bad day happening. And this does happen. We don't, in an acute situation, if we couldn't get them over to Addenbrooke's, yes, we'd treat them here with a cortical mastoidectomy. This is normally one of the children that we'd want to get over to Addenbrooke's because we have neurosurgery cover there, which we don't have here. But like many situations, if it's an emergency, it's an emergency, and we have to do what we're trained for. This is from the ENT UK and the British Society for Not Wasting Antibiotics. And so this is looking at the difference between the two, otitis externa, otitis media. Do they have ear pain, otitis externa? Yes. Will they get ear pain, otitis media? Yes. But once it starts discharging, normally because the pressure has been relieved, it gets better. Otitis externa can have some really copious discharge, actually. But otitis media is the one that really hoses it out. Almost always, there's a preceding upper respiratory tract infection with otitis media, because it normally has to come from somewhere. But when you look in their ear canal itself shouldn't be painful. It may be a child that's trying to run away from you, but the canal itself shouldn't be painful when you put an otoscope in. That's painful from otitis externa because the skin is inflamed and a horrible doctor is coming along and putting something inside. Then you don't normally get swelling around the ear with otitis media. That's almost always cellulitis from otitis externa, and the canal shouldn't be swollen. If the canal's swollen, particularly with otitis externa, I'll give steroid drops as well. Otitis media is the one that can spread to the brain, and that's the one that scares us. And I know I've laboured this point because this is the one that everyone's very concerned about at the moment. However, like many, many concerning things, it's not that common. Perforated tympanic membrane. It can be perforated because they've had acute otitis media and it's perforated from there. It can be perforated because I've come along and done a myringotomy. I've put a knife through the tympanic membrane to try to drain off any mucus behind them, put a grommet in. It can be due to trauma. Hopefully it's not due to trauma in a little one. So when they've had barotrauma or they've had a big blow to the ear, and they tend to complain of ear pain when perforation occurs, and they may get some blood at this time. They'll get some hearing loss because their tympanic membrane isn't going to vibrate as well. It's not going to move the middle ear bones. They may end up with recurrent discharge. Most of the time, this can be managed conservatively. There's very little we'll do acutely with these patients. They tend to heal within 6 to 8 weeks if it's traumatic or an episode of otitis media with perforation. And if they get infected or there's a middle ear infection, because now the middle ear is exposed, then they can be treated with topical ciprofloxacin ear drops because it's a higher concentration. It will get right into where the infection is. They may complain of a bit of a burning sensation in the back of the throat if the eustachian tube is very patent, because it will just run down from there. And then after a while, these may need to get, reconstructed. And this lovely picture is from EM docs. Foreign bodies in the ear. This is the slightly gross one. What do we think's on the left?
Is it an insect?
So I'm going on my left. So on the far left here, can you still see my pointer, AJ?
Yes.
Lovely. So on the far left here, that's some wax. Wax causes no end of problems in the ear. The NHS doesn't fund the removal of wax unless it's causing symptomatic issues. So in our emergency clinic, we do wax removals for people that are having lots and lots of issues, but it isn't something that happens straight away. On the right is a really gross insect. The way that the trust advised to get rid of it is that clearly call us. We'll put olive oil down the ear. However, the trust doesn't actually give us olive oil, therefore we have to buy our own. And the alternative being mineral oil or ciprofloxacin ear drops. And you're basically trying to drown it. The main thing we care about this is obviously on the left, super creepy, because having an egg sac in there, along with loads of spiders, is definitely off, is a button battery. And it always comes back to button batteries. Most things that are in the ear can wait. They can be removed in a nice, safe setting with a happy child under a microscope, which is the safest way. The emergency end being something that's going to cause damage, and the main thing for that being a button battery. Kids put things in their ear all the time. Adults tend to break off bits of cotton wool or bits of tissues. Occasionally, I've had one person put an iPhone charger in their ear because it was itchy and then it broke off. But that tends to be the adults. I have a slightly different conversation with them. But the main thing we care about, button battery, they get rapid erosion. It eats through the bone. This is the type of stuff we'll take them to theatre overnight. And we definitely won't put eardrops in button battery ears because we're worried about making the connection. If it's long-standing, they can have a foul smell or there can be some blood, but it needs to be removed in the appropriate area. So lots of the time, if you see these kids and you think it's infected, provided it's not a button battery, which by the time it gets infected, it's not, we will give some ciprofloxacin eardrops and bring them back to clinic to remove in a safer setting using a microscope and a play specialist normally. The next section we'll be going on to now is noses. So basic bit of nose anatomy again. You've got the root of the nose at the top. You go down onto the bridge. Nose, ignore the posh words, alar and apex. As a general rule, if someone's going to get a fracture, we worry more about the nasal bones over here. Children don't typically get full-on nasal fractures. They're still quite bouncy, and we always worry about safeguarding in that context. Epistaxis, very common in children. The main amount of it is minor trauma, which is generally nose picking a lot of the time, or shoving things up their nose. Over winter, there's a bit more epistaxis because the nasal mucosa dries out. And in areas with high airborne particulate concentration, they can also get epistaxis as well because it irritated it. Nasal foreign bodies we've just discussed. Children with migraine headaches tend to have a higher incidence of recurrent epistaxis. And essentially, you've all heard of Kessel-Black's plexus, load of blood vessels right at the front. They all get together, they get a bit prominent. We tend to manage this with cautery. Most of the cautery is done just in clinic with a bit of local anesthetic spray, if any spray is needed at all. Children that had repeated cautery, occasionally we need to go to theatre. Sometimes if little ones have gastroesophageal reflux into the nose, they can trigger some inflammation and they can get some epistaxis from there. Now, the weird, wonderful things here to be aware of: liver disease, which can cause clotting deficiencies. This is always where I get a lisp in the morning. Hereditary hemorrhagic telangiectasia. A lot of the time you'll be able to see these on the children and know they're somewhere else. They respond slightly differently because they're bleeding from everywhere. And a lot of these times, these children are managed using lasers. Autosomal dominant diseases that cause capillary fragility of the skin. And then there's a very nasty condition called juvenile nasal angiofibroma. Only happens in males, which causes normally severe unilateral nasal bleeding. So a lot of the time, if a child is having recurrent nasal bleeds and they're heavy, we're not talking about a bit of spotting, they're really heavy ones, then they're the ones that we'll end up doing a scope on, and we're looking to see, is there a growth at the back of the nose? So it's just something to have in the differentials. But this is more our problem because we end up bringing these children back to see us in clinic if we're worried about them. Nasal bone fractures in a child, if we're worried, we'll bring them back 7 to 10 days. We'll have a look at them then, but they're quite squishy and a lot of the time they're fine. Much like pediatrics, normally the kid is fine, but we're having to treat the parental concern on here. Apart from AJ, because he keeps on calling me up about these. What's going on here?
Looks like it could be a septal
hematoma.
Yeah, perfect. And we get lots of phone calls about septal hematomas. And if you're worried, we're happy to come down and look. Because these, again, these are the things we don't really want to miss. But the main thing about a septal hematoma, it's coming from the nasal septum. Can be a bit tricky in the nose at times. A lot of the times when we get these, not from hospital, but more from outside, it's the inferior turbinate. If it's coming laterally and there's a gap, it's the inferior turbinate, which my boss will have asked me to mention. If you're worried about a septal hematoma, we're happy to see them. So you get the blood between the perichondrium and the septal cartilage. The concern of that basically is that, as we know, cartilage gets its blood supply from the area around it. You end up with a nasal perforation from it. It's drained. It's not very comfortable to have drained. Can be unilateral or bilateral, tends to be bilateral. Over time, gets infected, the nose drops down, you end up with a saddle deformity. You can do this on the local anesthetic, but in a child, that'd be pretty bold. We would bring these children in and do them under general. So it's just about having a look up the nose. And if you can't see one, then there's probably not one. And have a feel of the nasal septum as well, which is always super fun. If it feels like a normal firm nose, and if you feel on yourself, you'll know what a normal nasal septum, well, hopefully normal nasal septum feels like. That is what a normal nose should be like. If it feels boggy, that wonderful word that's used in so many contexts, then the concern is about that. And as I said, there's always lots of waiting, but we'd rather not miss one because it's a right pain to reconstruct. Sinuses. The reason we're talking about sinuses is then we're going on to kind of periocellulitis, which is ophthalmology, but as ophthalmology don't really keep in patients in a lot of centers. Lister, they tend to be joint care with ENT and pediatrics. So sinuses develop once you're at age 10, they're kind of closer to normal size. They're pretty titchy most of the time, and there's massive variability between them. The main things we're looking at, we've got our frontal sinuses, ethmoids, and maxillary sinuses. But they're part of the drainage system, and because humans aren't designed particularly well, they don't drain properly when we're standing upright. So pericellulitis, we have to think where it's come from. And so what it tends to be is unilateral. So we recently had someone who's bilateral, eyelid edema and erythema with unilateral eye pain or tenderness. And the differentials we consider in a little one, in a baby, we're thinking gonorrhea, chlamydial infections. If it's bilateral, we're thinking an allergy. It could be a sty that's got infected. It could be angioneurotic edema. It can be cavernous sinus thrombosis, or it could be everything from leukemia to a late presentation of retinoblastoma. So there's a horrendously large differential there. But the main thing is if you've got an unwell child with a unilateral eye swelling who's showing signs of infection, it's probably an infection. If the swelling is below the eye and you're losing the angle at the side of the nose, if you put your finger on your nose, run it to the right, and that groove there, the nasolabial fold, being a dentist by background as well, that is where you get canine infections and canine space infections going. So it's not uncommon for ENT to end up admitting someone for a canine space infection while they're waiting for it to be diagnosed as not a periorbital cellulitis. And certainly in my lifespan, I've seen that a few times. But as we can see here, normal eye, periorbital cellulitis, inflammation around the eye. This is from the same guidelines then, because trying to work out if it's preseptal or postseptal, that tiny orbital septum, which causes so many problems. The way I look at it is I find this guidance quite helpful. If the eye is going forward, there's proptosis. And the way I look at that is I stand behind the patient, I try to put a finger roughly where I think the eye is on either side, and I look to see, has it moved forward? It is easier when there is not a bulging eyelid. Hypoglottis, so the eye is going down, I'm more worried about there. Diplopia, if you can get both their eyes open, and I'll tell you my trick for opening up the eyes. If the eye movements are restricted, again, I'm concerned it's postseptal. And these are the individuals that ENT will admit and give a CT to work out what's going on. And if they've got a terrible headache, because the thing we're scared about is we're scared about an abscess forming. We took one little one to theatre yesterday for an abscess. And what we're worried about from there is the spread backwards into the brain, because unfortunately along the optic nerve and then we worry about cavernous sinus thrombosis. So things that are associated with increased disease, if you're worried, clinical suspicion, you're all experienced clinicians, if you're worried, then we're worried. If the kid is systemically unwell, if they've had oral antibiotics for 2 days and they're not getting any better, if you've got a child who's getting better after 2 days or a child who's staying roughly the same, then it's normally okay. If they're septic, we just do our normal, wonderful sepsis 6 management. And if they've got a history of a bit of mild trauma, their eyes normally had a history of insect bites, it's fine. When you've got a child that's got quite an edematous eye, it hurts for them to open it. And I tend to treat these the same as I do my orbital fractures. I put my fingers on the eyelid and I let it rest there, because there's normally a lot of edema there. And once you push the edema out the way, you can normally gently open up the eye. If they've got colour vision, I'm happy enough then that the optic nerve isn't too stretched. These children need to see ophthalmology. Pragmatically, these children normally come in under peds and ENT, and we try to arrange an ophthalmology review. So you've got preseptal cellulitis here. It's just in that area there. Antibiotics, manage the cause there. Orbital cellulitis, it's gone in. We've got inflammation there, inflation of the orbital muscles. They'll complain of some painless moving. Subperiosteal abscess. This is mainly the ones that are from the sinus in origin. So we've got our sinuses over here. And there's a tiny bone called lamina propria, means paper thin. The one that when you've got a CT head report for someone that's been punched, it says it's fractured, because it is paper thin, it fractures as soon as you look at it. And they've got a subperiosteal abscess. Then we've got an orbital abscess, slightly more concerning, because the infection is now within the cone of muscles, and we've got our optic nerve there. As the infection pushes, the globe will continue to be pushed forward, the optic nerve will be stretched. These children will be unwell. And the scarier thing from there, cavernous sinus thrombosis. Hen's teeth, very, very rare, but something to be aware of. And as children, they can't always normally express as well as adults, though not all adults can express as well either in terms of what they're feeling. So it's about having that clinical suspicion. So cavernous sinus, fever, headaches, about 50–90%, some periorbital swelling and pain and vision changes. Starts with one eye, moves the other one. And what we'll see from there is that the talk about this picket fence line, the pattern for septic thrombolysis. The end result is if you've got an unwell child who's tachycardic and hypotensive, these are the ones I'm very worried about. Seizures are quite rare, but the eye findings are nearly always universal. So if you're worried about it and they have an ophthalmoplegia or you're very concerned, then we call for help, which is what I do. Foreign bodies in the nose, because children love foreign bodies in the nose because it's used as a nice place to store things. Typically presented acutely, parents have seen it gone in, or they may have noticed that something is missing. This is before they've caused an issue, and they may just have a unilateral nasal discharge. On the left of the screen, we have some sort of round object. On the right, we have a dreaded button battery. And the first thing you'll normally be asked if you call us is it a button battery or not? And that's the thing that worries us. After that, we're slightly worried because it's in the airway, even though there's never been a case report of one of these actually spreading further back and causing it. If a child has had a large foreign body in the nose and then had a choking episode after and turned blue, then we're worried it's descended further down in the airway and they may need a bronchoscopy. So it's an irritant in the nose. You get a unilateral nasal discharge. There may be nasal obstruction. The child may be pouring at the nose, trying to poke and prod their nose. If it's been left in there for a while, it can cause kind of infection. And a lot of the time we'll safety net. If we can't see one in there when we've had a good look, then actually we'll safety net. Then if the parents notice a unilateral nasal discharge that's getting worse, to bring them back. And then we'll have a look under general anesthetic. A lot of the time when we see it, we try to get it out to avoid it. This is what happened if a button battery is left in. It erodes away at the nasal mucosa. You get a nice chemical reaction going on as the electricity is going through, and we join the two poles together. And this is what Miss Stevens asked me to raise up. This is the double ring sign there. So if we're worried about a button battery, we follow orthopedic principles. We take views from two different angles. And what we'll see here is a double ring sign. So what we're noticing here is there's one ring and there's a second one. And the way to differentiate this from a coin is that if you take a view from a different angle, so straight on, or from the lateral, depending on the way it's been put on, you can see that there's this shape down here that it follows. And this is the button battery. These are the ones that we'll take to theatre to remove. You'll be happy to know we are almost done. So the main thing is if you're worried about a button battery, we need to take it out. So now we're going to talk about the throat. I suspect everyone here has significantly more knowledge with me about this one there, but little ones are different. The nose is a bit smaller. They're not completely obligate nasal breathers, despite what they say they can breathe through their mouths, but it's a general thing that's taught, so I'm not going to fight that one too much. Their jaw is small. Their jaw will develop. They have this omega-shaped epiglottis that's a bit floppy. I'm not going to talk about laryngomalacia in this area at this point. They have a big tongue, high larynx and narrow-glottis. And when they're sick, they're sick. So the main thing with this, is that the larynx is smaller. Generally, what is said to be the narrowest portion is at the cricoid below the vocal cords. The epiglottis is longer and narrower. And the adenoids are massive, so they get in the way as well. The difference between the pediatric and the adult airway again. And the next trigger warning is you're going to hear a noise that may trigger some fear in you, because it certainly isn't a noise I'm happy to hear. Hopefully it works. Not particularly a noise that I like to hear. This is a scoping video of an adult who I saw. And this is around the time I thought in my head, wonderful, what a great day. So I can barely see the vocal cords below there. You can see inflammation around the area. And you can see all this lovely mucus and secretions going straight down into the airway. So this was when I had a good look around then. And it's useful to see on the scoping videos to see what we're dealing with, because this is the same view our anesthetic colleagues will get. I wouldn't have scoped a child if I was worried about this. Is the Latin origin. It means to creak or to squeal. According to my Google search this morning, unfortunately, I stopped studying Latin at a very early age. And when we're thinking about this in children, we've got infection. So croup epiglottitis or foreign bodies are more common. There will hopefully be a history of a foreign body. If it's a foreign body, it's an emergency, it's in the airway, it needs to come out. If it's croup, as my pediatric and EM colleagues, you manage this amazingly, and therefore I never hear about these children, though my ears always perk up when I hear lots of strange noises in the emergency department. And epiglottitis, which is very rare, thankfully, due to vaccines, which we'll talk about. But as the world is progressing and perhaps we're not seeing as many people having said vaccines, it's now probably going to become more common, unfortunately. And then there's congenital causes like laryngomalacia, normally present from birth. They'll have desaturating episodes we know about, and hopefully they grow out about it, because the majority of the interventions don't seem to provide us as much joy as we wish they would do. And things like subglottic stenosis. So shortness of breath, particularly on inspiration, stridorous. They talk about the stridorous patient. You can classify it into inspiratory, expiratory, or biphasic. And most of the time, this is the general guide that we follow. So if it's inspiratory, we think it's an obstruction between the glottis and the supraglottis area. Expiratory suggests to us the obstruction is below the carina, and biphasic normally says it's between the glottis and the subglottic area. And we look at it, we think about a change in voice and a cough. Stertor is noisy breathing, which occurs above the larynx. And stridor is noisy breathing, which occurs at the level of the larynx or below. And hopefully you never end up with an X-ray like this, though it will definitely happen at some point. And it is sometimes quite helpful in the stable-ish patient to get it there. We can see the inflammation around there. So epiglottitis, cellulitis of the supraglottic region that can cause airway compromise. It's an emergency, especially in kiddies, and typically described between ages 2 to 6, but it can occur at any age. Since the wonderful development of the routine Haemophilus influenzae type B, the Hib vaccination is there. It's quite rare in children, it's more common in adults. You have a kid that's unwell. They've got a high fever, their throat's sore, they're like pooling secretions that are coming out of their mouth, and they're there tripoding. They've got their hands, they're leaning forward the same way that I do after a run to try to get as much air in as possible. Most children need intubation, as opposed to only about 11% of adults that need intubation. And this is when, if you're worried and you've got clinical suspicion, you call for help. So that means we get an anaesthetist, because the end result is they're the airway experts. You call me, I call my boss because I need help. We need pediatrics, we need emergency medicine, and everyone's together is there to keep this kid safe. We can waft some oxygen, but we don't want to do anything to stress out the child. This is when we'll intubate in theatre if we've got time. Once the airway's safe, then we're in a much happier place and we're giving antibiotics, it will tend to resolve. Just because you've had vaccination doesn't mean you definitely won't get it, but it's a damn sight more common if you haven't been doing it. And you've got a kid then who's drooling, high fever, toxic, and hopefully no one ever sees this. What is perhaps something we see a bit more is we have tonsillitises, and what happens is eventually if they've had some antibiotics, and unfortunately they're one of those unlucky ones that doesn't get better, they get a peritonsil abscess, or the eponymously named quinsy. The main things we're looking for are a deviated uvula there. So we can see the uvula's been pushed over. When you're looking at these children, they've got big chonking tonsils. What can sometimes happen is the uvula at the base is in the midline, but because the tonsils are quite kind of sticky, the tip of the uvula can be just stuck to a tonsil, so it looks deviated. If you're worried, we're happy to see them. If you've got someone who's got worsening symptoms, they can't eat and drink, they've got trismus, the end result is they're probably going to come in anyway, especially if they've had treatment. What we do sometimes think about is deep neck space infection. So I'll always ask the patient to move their neck to the left and right, and I'll see if there's a true restriction. There are things like leukemia that can cause this as well, but hen's teeth again. Retropharyngeal abscesses, this is where things progress to. Slightly more common in children and adults. They've got difficulty swallowing and trismus on a background of a neck infection. And so looking through there, bottom jaw, top jaw, spiny stuff, going through there, going along, and what we see is this playing along here. And so we talk about the retropharyngeal space. All these spaces are potential spaces. They don't exist really until there's an infection, and it's where things commonly go to. And I'm aware my time is running out. So we'll talk about the wonderful post-tonsillectomy bleed. So tonsillectomies are done for various reasons, mainly due to recurrent tonsillitis, but they're also done for sleep apnea surgery. And occasionally, if someone wants to take out the stylohyoid process for Eagle syndrome, they're also obviously done for cancer as well. So typically there's two patterns. If it happens straight after surgery within the first 24 hours, that's our primary bleeds. And that's normally due to tiny vessels that pull themselves away during the surgery that we can't see. If there's not, people aren't eating and drinking properly, the muscles don't construct around them, and then they spurt open, and it can be because tie slip. Normally, if it's a primary bleed, it will happen from both fossas. Well, that's much more common. If it's an adenoid bleed, so adenoids being kind of hiding up behind here, just in this area, the blood may be coming out through their nose and they may get horrendous nosebleeds, but the principle is the same with these here. This is the trust policy that we follow at Eastern North Hertfordshire. If you are in a different hospital, please follow your local one. If it says active bleeding involved, the ENT SPR almost never happens. We get the first phone call because our SPRs are off-site and potentially half an hour plus to give help. So the standard things that we do, sit them up if we can, and certainly I've been in resus with AJ when we needed to transfuse someone. Full blood count using his coag, cross match, 2 units. We give tranexamic acid, antibiotics, analgesia. If it's a child, slightly more different, but most of the time it isn't a serious bleed. But ideally, if we can still get some bloods on them, that's always great. And ideally a group and save as well, because sometimes, much like other parts of the body, it can be a sentinel bleed. What we worry about is we will almost always admit these patients. What we worry about is more that this is the first bleed and they get a tiny one and then they hose out later on the ward, and that does sometimes happen. And then occasionally, if I'm really worried, I will get something and shove it in the tonsillar fossa and hold it there until I can get them into theatre to stop them bleeding. But as always, you just follow the normal A to E approach and we treat them as part of a team, and then hopefully we keep them safe. And that has been almost 50 minutes, and it wouldn't be ENT without some sort of kind of assessment of the swallowing as well. That is my Twitter. That is my email address. Thank you very much. I will try to answer any questions you have, provided I've not put everyone straight to sleep.
Thank you so much, John. Do we have any questions? I'll open the floor up for any questions.
Hi AJ, I don't know if you can hear me okay. I'm home now. Just wanted to ask, we're often advised to avoid antibiotics with the otitis media, otitis externa in our trusts across the region, different guidelines. Just wondered if there's any way to kind of rationalize these antibiotics in the quite well patients.
So if they're quite well, they're probably going to get better, is not what we say. So I'll find the policy, which is what ENT UK and the Society for prevention of over antibiotic use have said, and I will put it in there. And essentially, if you are concerned, a lot of the time we give antibiotics. Most of the time the children will get better. They give nasal decongestants. But if you have an unwell child, then I would almost always treat. But my perspective is slightly skewed because I tend to only see unwell patients. So I don't tend to see the ones that aren't too unwell. So the advice is normally, if it's particularly mild, and if their symptoms have gone on for less than 3 days, then they don't need antibiotics unless there's significant risk factors. If they're age 6 months to 2 years, they will get, and they have bilateral symptoms, then they'll end up getting antibiotics. If they're immunosuppressed, they're going to get antibiotics. But if you've got a child who's got moderate infection and they've got fever and they're feeling really unwell and they're not getting better after 48 hours or a couple of days at home, then they treat. But the problem is, it's, as with a lot of things, the advice is you've got your national guidelines and then you've got your local guidelines. And a lot of the time, without being too defensive, people tend to follow what they've got locally because you're looking at how you may be penalised. So unfortunately, where are you at the moment?
Norwich. I think
Norwich.
it's now just accessing GPs. So often you're kind of giving them a rescue antibiotic prescription in case things get worse, knowing they'll probably just go and cash it in.
Yeah, unlike Norway, I don't think our rescue policy works very well when it comes to antibiotics because people take them anyway. Yeah. I put on the British Society for kind of antibiotic conservatorship link on there, which is generally what I follow when I see these patients.
Cheers, thank you.
And I tend to look it up even now. I think, like many things, as long as you've written your reasoning and you can justify your decision and you can safety net, then you'll probably be okay. We do have, unfortunately, ED being the front door that's never shut. These patients will hopefully come back if they are not getting better.
Mm-hmm.
But it's all about this shared decision making, which a lot of the time they seem to forget when they come back the second time and they say, this doctor didn't give me antibiotics.
Yeah.
When they needed it, which then becomes one of the issues. But if you've got a child that's got a perforation, then you can just treat them topically as well. And sometimes when you're treating them topically, it's about selling to them that actually it's a higher concentration topically and it's going to get right to the area versus oral antibiotics that go everywhere.
Because often we won't have in stock in A&E access to anything other than the bog standard kind of oral antibiotics out of hours. And it's the other thing is I was always told if they've perforated, you're risking injury to the inner ear depending on what you use and things. So I think we're quite wary of using things in that situation.
Ciprofloxacin is considered to be non-ototoxic.
Okay.
And it's safe. Some of my, that's what I've always stuck to, and that's what my bosses stick to. So I've done it from there. Gentamicin, I know one person that does out of everyone else I've ever worked with. I wouldn't put gentamicin through there because we do know that causes issues. But ciprofloxacin is what we advise, especially if there's perforation, because it avoids the area getting colonized.
Okay.
And a lot of the time when we see these children, if they come in, they've been on a course of amoxicillin, they've not got better, and there's a perforation or there's a grometin, we'll give them ciprofloxacin and we'll say, we'll see you again in a week, come back to our emergency clinic, and they come back right as rain in a week, or they just don't turn up. And when we phone them up, it's because they're better. And they said, oh, I didn't realize I had to turn up.
Okay.
As always, it's the de facto answer of your local policy. Because everywhere works slightly differently. And in theory, that's because of different antibiotic resistance in different regions as well.
Thanks.
Sorry, it's not very helpful.
Oh, no, it was very helpful. Good to know. Thank you.
Oh, thanks for the talk. Can I ask about earwax?
Yeah, ask away. My favorite topic. Can make candles out of the amounts I've taken out.
So what's the usual advice you give from, for care at home type stuff? If it is really, obviously, if it's not bothersome, then it's not, there's no advice to be given, but if it's causing issues.
So the normal advice I'd give would be to, if it's not causing an issue, but you look in a kid's ear and it's full of earwax and they're doing okay at school, I'd just say use some topical olive oil the body will break it down, keep the ears dry, the exception being the olive oil. So olive oil morning and night, pharmaceutical grade ideally, and tell them to use it at room temperature. You will get someone that will heat it up, and then that causes a whole different set of issues, much like steam inhalation, which we stopped advising because people keep on trying to burn themselves with it. We now say room temperature olive oil from the pharmacy with a dropper. Put it in both ears, it will soften the earwax. The earwax will break down and come out naturally. If it's causing particular bother for them, because you can have people complaining that they're dizzy, that they're not getting better at school, then they'll normally end up coming to the ENT acute clinic, whatever your local ENT acute clinic is, and they'll be seen in about a week or two. And they use olive oil between then because it softens it up, and then it comes out like a thick slurry instead of a small child you're fighting with for like half an hour to try to take stuff out of their ears under a microscope. So that's my normal thing with earwax. If it's causing bother and they're symptomatic, then we have a justification for removing it. It's not a particular clinical priority compared to a horrendous external ear infection. Despite it's very important to that patient, it's perhaps less important in the consideration of the whole service. So they'll normally come back in a week or two after the olive oil has softened it. I don't tend to use bicarbonate drops very much because it tends to be quite irritating to the external ear canal. And sometimes if there's someone who's got a history of eczema and you use bicarbonate on them, then their ear canals just swell up massively.
Right.
So olive oil very rarely causes any harm. And that's certainly how I treat myself if I need it as well. And as a shout out to Lister Pharmacy, they sell it for like £2.50, which is the same, which is slightly cheaper than Boots. Right. If I haven't traumatized everyone too much, thank you very much. I hope that wasn't too much like trying to suck eggs on there. I was just trying to go through the main things. The things I've not talked about on there include pharyngeal foreign bodies. Depending where you go to, or depending which hospital, there may be division. At Lister, the ENT consultants are very keen to take any sort of high up esophageal foreign bodies because they're very keen for their registrars to get more experience in that area as well. So what we tend to do is we'll take, especially in adults, esophageal foreign bodies, provided we can get to it with a rigid scope. So despite my dislike of ever being called for anything, please refer those patients to us because we're happy to take them. And especially if it's a kiddie, we're happy to take them because the gastro team, unfortunately, if they need a rigid esophagoscopy or a rigid pharyngoscopy to remove something like a coin, we have the equipment. The main thing we care about is we hope it's not in the airway. Thank you very much then.
Thank you so much, John. If nobody has any more questions, I will now introduce Suresh, who's one of our registrars at the emergency department, who has an interest in pediatrics, and he spends most of his time in Peds ED. So I'm going to now open the floor up to him. You can share your slides, bro. Thank you so much.
Yeah, thank you, AJ. Good morning, everyone. So I'm going to share my slides just a moment. Share screen. Can you all see my presentation, and am I audible?
You're audible. You can see your presentation.
Yeah, okay. So today I'm going to talk about a case, a patient that I had seen in pediatric, in our A&E in Lister Hospital in the Pediatric Bay. So today I'm going to talk about the case. So it was a child who presented with a low motor neuron, seventh nerve palsy, the Bell's palsy, and then I'm going to speak about a few interesting case reports, articles, and studies that I came across after I'd seen this child. And we're going to end this discussion with some learning points, and I'll be happy to take some questions at the end of the presentation. So in the A&E, oh, sorry. So this was a 6-year-old girl who was attending the A&E with her mom. Let me just minimize this. Yeah, with a mom. She came in with a 1-day history of right-sided facial droop and with some rashes on her right cheek. So there was a birthday party. I think it was her older sister's birthday party at home. Mom was taking some pictures and she saw this lopsided right-sided face. So mom got her to A&E. Other than the changes in the face, there was no other associated features, like there was no ear ache, no vesicles on the ear. She had no headache, no blurring of vision, no limb weakness, no fever. Past medical history wise, this young girl, she had COVID infection 2 weeks ago, recovered absolutely perfectly without any complications. Other than that, there was no other past medical history. She was not on any regular medicines. She had no allergies. She lives with her parents and her older sister. Her immunization was up to date. There was no history of any travel. During examination, the child was irritable and she would not cooperate during the physical examination. Obs-wise, she was absolutely fine. On neurological examination, she was moving all 4 limbs, but refusing a proper, thorough examination. On examination of her face, I could see the face, the angle of the mouth was deviated to the left, and there was drooping of the right eye, and I could see some erythematous rash on her right cheek. I could not see into her external auditory canal properly because she was refusing examination, but I could not see any rash on her ear. Other systemic examination was absolutely normal. So I spoke to my pediatric colleagues and they said they're going to come and see the child, but I was told that we need to do some bloods just to find out whether we're missing anything or is there any associated thing going on along with the facial nerve palsy. So we did bloods and the routine bloods did not show anything remarkable. Her white cell count was 8, neutrophil was 5, biochemistry, UNEs, LFTs, everything was within the normal limit. We did some blood cultures and it did not grow anything. We did HSV 1 and 2 IgG antibody and Borrelia IgG antibody, which was not detected. So this young girl was seen by my pediatric colleagues and she was admitted in the CAU. Initially, she had a House-Brackman grade 4 facial nerve palsy, which improved overnight to grade 3. She developed some more facial rash in the V2 dermatome. There was, after she calmed down, my pediatric colleagues could have a look inside her ear canal and they could not see any rash or any erythema or anything abnormal in there. And the tympanic membrane was absolutely fine. So this young girl, she was treated with oral prednisolone 20 milligrams for 7 days, followed up by weaning over 3 days. She was started on acyclovir and she was given an eye drop. She was discharged after the morning rounds, after being seen by the pediatric consultants, and she was sent home from the ward. The plan was to be followed up in the ENT clinic after 2 weeks. So after I spoke to my pediatric colleagues, I came to know about this classification of facial nerve palsy. So I've included this in my presentation. This is the House-Brackman grading of facial nerve palsy. And in this, there's 6 gradings. And grade 6 is the total paralysis when there's no movement of any muscle of the affected side. and grade 1 is normal. So this child, she came in with grade 4, where there is moderately severe dysfunction, and she then improved while she was in the ward to grade 3, which is moderate dysfunction, and she was discharged with grade 3. So after I seen this child, I did a bit of a digging, and I came across a few case reports, a few studies, whether there is any association between COVID-19 and Bell's palsy. So there was this study which was done in Wales, and it was done in the Royal Glamorgan Hospital. So they did a comparative study retrospectively about between a few cases which they had seen in pediatric age group in 2015 and then in 2020, but they could not find any causal link but at the end of the study they have mentioned that this was a very small study, so it is very difficult to say whether there was any link between COVID-19 infection and Bell's palsy or not. This was a case report, and this was published in one of the radiology reports, in which one of the there was a 23-month-old girl child who came with a Bell's palsy, and the MRI was done, and they found there was a cranial nerve neuritis, and this child had COVID-19 previously. So they said that COVID-19 should be considered on the differential while evaluating causes of new onset peripheral nerve palsies. This was just one case report. This was a 37-year-old man who was admitted in the hospital after having COVID-19, who developed myocarditis, and then he returned to the hospital after being discharged with a unilateral facial nerve palsy. And they did all kinds of tests like Borrelia antibodies, CT scan, blood tests, and they infer that this could be an atypical presentation of COVID-19, and COVID-19 could be a reason for the unilateral facial nerve palsy. This was a big study which included 348,000 patients, and if you look at this chart on the right side, so out of 284 patients, they found that 153, these are all 284 had COVID-19, and out of these 284 patients, they found 153 were new onset facial nerve palsy, and 131 of the 284 had Bell's palsy in the past. So there was a recurrence of Bell's palsy after they had after they had COVID-19 infection. So what they're saying that there could be an association between COVID-19 and Bell's palsy. So the learning points is unusual presentation of COVID-19 present a risk of being overlooked, leading to delayed diagnosis, isolation, and effective management of people with the infection. If we come to the third point, Bell's palsy secondary to COVID-19 infection can occur and is likely to be an autoimmune pathogenesis. So, sorry. So, what I gathered from these papers, these presentations, the studies, is that though none of the case presentation, none of the studies say that there is a conclusive evidence that COVID-19 could be a cause of causing Bell's palsy or a recurrence of Bell's palsy, but the studies point towards keeping our eyes and ears open if a patient has Bell's palsy and COVID-19 earlier, there could be an association between the two. Thank you so much. Does anyone have any questions at all?
Thank you for that, Suresh. I'll open the floor up for any questions.
Thanks for that talk. I was wondering what the practice is across the region in terms of so sort of straightforward Bell's palsy investigation and management. Sort of curious to know whether everywhere within the region is using steroids plus or minus acyclovir, and the level of workup that we're doing for Bell's palsy. Obviously, we'll take a detailed history in every case to make sure that there aren't any significant historic features. But just in terms of whether everybody is getting, you know, viral serology and things like that.
When I presented this case at Lister Hospital, where the pediatric consultants, A&E registrars, pediatric registrars were present, we had a discussion, and the overall idea about management of Bell's palsy was that, yes, we do steroids and acyclovir. The other point that came up from investigation point of view was that whether we should have scanned this child, like a CT scan of the brain. But there was a debate, and we did not reach a consensus whether we should have CT scanned the child or not.
Yeah, I mean, I guess these are all the investigations that are available to us and all the treatments that are available to us. That's the question.
My question was, does everybody in the region, I mean, start acyclovir on if for all low motor neuron facial palsies, if there isn't a particular indication to start acyclovir? Like, for instance, if you do not see a rash or anything suggestive of herpes zoster, do you start acyclovir routinely?
I mean, if we have our pediatric colleagues in here, they might be able to answer this.
Because in adults, we do not start acyclovir unless it's absolutely like visible that the patient has
like a Ramsay hunt.
Like a Ramsay hunt,
yeah.
exactly.
Yeah.
So do we routinely, I mean, again, blood salts are not indicated in adults who come in with an LMN facial palsy, but that's something that after your talk, I think we do routinely. I mean, do we routinely send bloods in children who come in with facial palsies? Number one, number two. And then do we start the patient on acyclovir? So, you know, if your viral titers are positive for herpes zoster. So I'll leave that up for anyone who's more knowledgeable than me on this particular topic to answer it.
Yeah, I can see in the chat section, Anbin has written steroid in my region, no acyclovir.
So from an ENT perspective, we recently had a departmental teaching on this, which has kind of changed. So in the past, I would just give steroids as well, because that's what I've always been taught. Don't give antivirals unless there's COVID evidence there. And all the research that was done with steroids. But from what NICE says there, they may have a benefit. The problem is acyclovir is not the safest thing in the world, especially there. So normally what I would do is, unless someone has a significant renal history, is I will give acyclovir as well. But I will be telling them to drink a shed load of water, because what I'm worried about is precipitation in the kidneys of the acyclovir crystals. So following the departmental teaching, I changed my practice, because this is from one of the ENT registrars saying, well, if it was me, the one who did the teaching, I would have steroids and I'd be giving it, the NICE guidance seems to suggest also for 2 weeks as well. And I would, unless there's a really good reason, I would take the acyclovir as well. Normally, if it's an adult, if it's a child, we may be asked about them, but pediatrics will normally follow them up. The one that you've seen, if you wanted to, you can send me the details. I can see if I can find the SIPS clinic letters to close the case for you. Yeah. Because the likelihood is they would have come through there. I can see someone's very kindly put the nice knowledge summary on there as well. From the adult perspective, we tend to get phone calls and we'll follow them up there in clinic. And if they're not improving, then we will image them. But we'll look to see if they're improving, the thing being that Bell's palsy being a diagnosis of exclusion. So we're happy that we don't have any parotid masses. We're happy we don't have other causes. In terms of CTing a child, with adults, we CT a lot more. With children, we're obviously a lot more concerned. And I think considering that they've gone from a House Brackman's 4 to a House Brackman's 3, which means that the eye is already a hell of a lot safer, the eye being the main thing that we're concerned about actually in ENT, because we're worried about them ending with a corneal ulcer or something else. I wouldn't have CT'd them. With my consultants have done it. I'll have once I get the details, I can ask my consultants what they would have done as well, and see if I can get a straw poll and feedback to you. But I think it's one of the things that, provided that you have a decision and you can justify your decision making, then I don't think there's really a right answer on it.
So has everybody or anybody been seeing more cases of COVID-19 associated with facial palsy, or is this something that we've seen rarely? And if so, is acyclovir going to work if you think it's COVID-19?
Yeah, so I personally haven't seen it. I guess acyclovir isn't really. I mean, a lot of Bell's palsy, idiopathic Bell's palsy, is suspected to be a post-viral syndrome anyway, isn't it? My understanding. So that history that you give of a 2-week antecedent kind of positive test of COVID doesn't necessarily mean they need antivirals or sort of therapeutics for COVID, I suppose. Yeah.
Yeah, I do agree.
Have the other cases been a sort of acute COVID infection with a Bell's palsy?
In the case report, you mean? Yes, yeah, but that was not in the pediatric age group. That was a 37-year-old man, and that was a case in Norway. But he presented with COVID-19 and had myocarditis discharge, and then came back after 2 weeks with Bell's palsy. That was just one-off case report.
Yeah, it's interesting, isn't it? So I'm by no means a Bell's palsy expert, but I think there are a few things to say. One is, I think in kids we need to be really meticulous with our histories, and look for things in the history that are going to push us towards CT head rather than it being something that we would do as routine. I think particularly if there's signs of improvement, no kind of red flag features on history or examination. I don't think it's something that most people would go for early on. Obviously, if there are sort of features that are concerning, then by all means, it's absolutely the right thing to do, or a different type of neuroimaging. There's an absolute dearth of evidence for the right approach to Bell's palsy in children, and I think a lot of the practice comes from adults, is my understanding. And so this sort of routine administration of steroids is essentially extrapolation of adult data. Obviously, the earlier in the course it's given, the more of a role there might potentially be for it. There's currently a study that will be recruiting for the next 3 or 4 years, probably, going on in Australasia from the Eclipse group, sorry, the Predict group, looking at steroids versus not in children. That's been recruiting for the last 3 or 4 years. And I think COVID's caused some issues, and also just the numbers of Bell's palsy mean that it's going to be recruiting for a long time before it gives us an answer. It sounds like from the evidence that acyclovir is a useful adjuvant, and so in combination with steroids in adults, I think the evidence shows that there might be some benefit. But again, unclear in kids, and I think if you ask different people will have a different approach to this. I know that one of the neurologists in Adam Brooks feels that if it was his kids, he would want acyclovir alongside steroids. I don't know if I feel the same personally. I don't really have enough expertise. I think one of the concerns from a neurology point of view is, or just from a life point of view, apart from, you know, making sure we're not missing significant other things and the ophthalmic involvement, is long-term disfigurement. And so his feeling was that actually he sees a lot of these in clinic that get followed up because there isn't resolution after 3 months. That's the subset that he ends up seeing in clinic. And so anything, you know, that we can do that is going to reduce that risk is potentially beneficial. Whether or not acyclovir reduces that risk or not is unknown, I suppose. Yeah.
Yeah.
Sorry, that was just my understanding of Bell's palsy in kids.
Thank you so much for that. Does anybody else have any more questions? I'll take that as a no.
Yeah.
All right. Thank you
Yeah.
so much, Suresh. I know you've
you,
had a difficult night shift, and thank you so much for coming here and having a chat with us.
Yeah, thank you.
Thank you, John, for that talk as well. I have put up a feedback on the chat. If I could ask everyone to be kind enough to do that, that would be great. Yes, Ash, if that's it, shall we move on to the operational meeting?
Yeah, that sounds great. So anyone sort of in terms of sort of trust reps or committee that would like to join the operational meeting, you're very welcome to.
I'm off then. Thank you very much.
All right. Thank you so much, guys.
I need to do some Christmas shopping. Bye-bye.
All right.
Thanks, AJ.
All right.
Thanks,
Thank you so much, Mijan. Thank you so much.
Yeah.
This will be recorded. This has been recorded, and we'll, if anybody requires it, we will send it to them at some point.
Thank you, AJ. Thank you so much. Take care. Bye.
Okay. Thank you so much.
Thanks, Ajay. Thank you. Bye.
Yes. Super. Shall we stop recording for the operational meeting? I'll take some minutes and.
Amazing. Yeah, that's fine. I'm going to stop recording now.